Now the topic we are going to discuss is general anesthetics. So general anesthesia is a state where the body lost its consciousness. So the consciousness of the body is lost and thereby the person may feel the conditions of amnesia and analgesia. So the aim of the general anesthesia is to promote the unconsciousness to the person whereby the sensation of the whole body is lost, and it causes analgesia where the person won't be able to feel any pain, and amnesia where the memory status of the person is fluctuated or it is impaired. So, general anesthetics are the drugs which are used to produce loss of sensation of the whole body, and the sensation is reversible. So once the general anesthesia shows its action, then the person will gain the consciousness, and here whole body is involved, and these general anesthetics are prepared in the form of inhalations or injections. So, in order for a general anesthetic agent to produce its effects, it have to have some features. Especially the cardial features of these general anesthesias are they have to have the ability to lose all the sensations. I mean, the whole body sensation should be lost, and it should induce sleep and amnesia to the patient, and it should cause immobility or muscle relaxation. So the contraction of the muscle should not take place. The muscle movement should be immobilized and the muscle should be in the relaxed state, and it causes abolition of the reflexes. Whatever the somatic as well as autonomic reflexes which are produced in the body, that will be completely abolished. Now let us see the mechanism of action of these general anesthetics. So before going exactly into the mechanism of action, there are few terminologies or few considerations we have to make into consider. For inhalations, so there are inhalation anesthetics as well as injectable anesthetics. So for inhalation anesthetics, in order to show their mechanism of action, one feature, that is MAC, minimum alveolar concentration, is very important. So minimum alveolar concentration is nothing but the concentration that prevents the movement in response to surgical stimulation. So here the inhalations, if we give inhalations through breathing through air, it enters into the lungs. So once it is entering into the alveoli, the concentration which is available in the alveolar where it is causing, or else it does not respond to the surgical procedure. So if we are doing surgery, so it causes pain. So the amount of the gas which is present in the alveolar system in order to antagonize the pain or produce analgesia is called as the minimum alveolar concentration, and the stimulation is showed in mostly 50% of the patients, and it should correlate with the oil or gas partition coefficient. So what is partition coefficient? So it is the concentration of the solute which is present in two immiscible solvents or liquids. So if we are taking two different phases, like oil is separate phase and gas is separate phase, so gas can't be mixed with oil. In the same way, oil and water, if we take such two different phases where the amount of here the solute is nothing but the drug. So here the amount of drug which is present in both the immiscible phases, in both oil phase as well as gaseous phase, what is the amount of drug present, that is called partition coefficient. So this minimum alveolar concentration and partition coefficient, these both are aiding in the diffusible capacity of the drug, so that this drug shows the general anesthesia action. For intravenous agents, so for intravenous agents, potency of the IV. So potency, if we are giving through intravenous route, so the potency of the drug, which is defined as the plasma concentration that produces loss of sensation in response to surgical procedure. For example, here if we are giving through IV route, so to the surgical procedure, it should not show any response. In the sense, the person should not respond to the surgery or to the injury which is caused because of the surgery. And here we in the inhalations, it is able to measure the amount of drug which is present by the partition coefficient. But here we cannot measure the plasma concentration of the drug while giving through injectable route, because the drug enters directly into the systemic circulation. So here we can't take blood for every intervals and we check the concentration of the drug in the blood. So it is not that easy process or procedure. So we can say it is impossible to monitor or to determine the amount of the drug which is present in the systemic circulation or blood, which is given through injectable route. So here the main targets of these general anesthetics are the ion-gated channels or ligand-gated ion channels. So ligand-gated ion channels are those where the entry of the ions will take place into the membrane. So the main targets, there are various ligand-gated ion channels like sodium channels, potassium channels, and bicarbonate channels. But here the targets of these general anesthetics are the GABA receptors, where they are having chloride channels. So here the GABA receptor is a 5 subunit structure. GABA receptor is a 7 subunit structure where it is having the chloride ligand gated ion channel in it. So here the examples which are working through this mechanism of GABA receptors are the many inhalation anesthetics, barbiturates, benzodiazepines and propofol. They potentiate the GABA to open the chloride channel. So here if we see the structure, they go and bind. For example, if we take benzodiazepines or barbiturates, they go and bind to the benzodiazepine area or benzodiazepine receptors, and they will potentiate or stimulate the GABA receptor to open the chloride channel. So once the chlorides are getting inside the channel, there it causes the repolarization of the cell. In the sense, the cell will not get depolarized and thereby the pain is lost. So here the mechanism or the receptors they are binding is different. So all these general anesthetics work by this GABA receptor mechanism. Now let us see the stages of general anesthesia. If a general anesthesia is given to a patient, what are the stages or what are the phases is going to face? So stage 1 is analgesia. First the person will lose the sensation of pain, where the respiratory or the breathing in the thoracic cavity and abdominal region are equal. And here the ocular movements, the movements of the eye is in the normal state, and the pupil size, the pupil which is present in the eye, the pupil size is also in the normal state. And here the reflexes which are considered with eyelid, the person can move the eyelid properly, and the pharyngeal reflex, corneal reflex, and all these are in the normal state, and even the person can see properly. The visibility capacity of the person is also normal. And the light, here the light focusing, for suppose if we project light into our eyes, we can't react or we can't see the focus of the light for longer period of time. We just blink our eyes. So here the reflex towards the light in the analgesic stage is normal. And here the skeletal muscle tone is also normal in the analgesic state. Blood pressure and heart rate are also normal. So this stage of general anesthesia is preferred in the labor, to induce delivery or to induce labor, and to give incisions or to cuts to the skin, and for minor operations. The second stage is delirium. So this is a stage where the breathing in the thoracic as well as abdominal region or the respiratory movements are decreased little when compared to analgesic stage, and here the person will have roving eyeballs. So the eyeballs will be rotating, and here the pupil size is also increased, and here the eyelid reflexes are present but they are decreased, and pharyngeal, corneal and light reflexes are normal, but the muscle tone, blood pressure as well as heart rate will be increased in the delirium stage, and this stage is not that significantly useful. And the other stage, third stage, is surgical anesthesia. So in this surgical anesthesia, it is having 4 stages again. So in the first stage of surgical anesthesia, Here the breathing will be increased little, but the breathing frequency is, the breathing frequency is not proper, and the pupil size will be decreased, and there will be no reflexes in the eyelid at all. The eyelid movements are impaired. There will be no eyelid movements, and pharyngeal movements are normal. Pharyngeal reflexes, corneal reflexes and light reflexes are normal, where here the skeletal muscle tone and blood pressure are decreased. And in this first stage of surgical anesthesia, the heart rate is also decreased when compared to the delirium stage, and this is used mostly in surgical operations. And second stage of the surgical anesthesia, the breathing of the person is decreased. So the breathing capacity of the person is decreased, and the person will have fixed eyeballs. So here there will be no movement of the eyeballs at all, and the pupil size will be little decreased, or we can say it remains almost the same. And here the pharyngeal reflex is less, or else we can say the reflexes in the pharyngeal area are lost or it is reduced, and corneal and light reflexes are normal, and here the skin tone, muscle tone and blood pressure are decreased, and heart rate is little increased when compared to first stage. And the third stage of the surgical anesthesia, where the breathing in the thoracic region is completely impaired. Respiratory movements in the thoracic region are completely impaired, whereas in the abdominal region, the respiration is still there, and the person will have fixed eyeballs, and pupil size is increased. And here in the second stage, there will be no pharyngeal reflexes at all, but there will be decreased corneal reflexes, and light reflexes are normal, and there will be decreased skeletal muscle tone, decreased blood pressure, as well as increased heart rate. And in the final stage, there will be no thoracic respiration, and abdominal respiration is decreased. There will be fixed eyeballs, and pupil size is also increased, and here even the light as well as corneal reflexes are completely lost, and there will be complete narrowing of this muscle tone, skeletal muscle tone, blood pressure as well, and the heart rate is increased. And this is used occasionally. This stage of anesthesia is not that clinically useful. And final stage is that here also it will have fixed eyeballs, and the pupil size is increased. There will be completely, in the sense, almost the blood pressure and muscle tone are impaired, and there will be increased heart rate. And here the fourth stage is medullary paralysis. It causes complete paralysis. There won't be any respiration in this stage. So if the person is reaching this stage of anesthesia, we can say the person is almost in coma stage. And here the pupil size will completely be increased, and here there will be no reflexes at all, and there will be no heart rate, no muscular tone, and even the blood pressure is also, like we can say, there will be no functioning of these. And this stage is not that clinically useful, and this stage of anesthesia leads to coma or sometimes death of the person. Then it is the pharmacokinetics of inhalation anesthetics. So if the inhalation anesthetics are given to the patient, so what happens in the body? So they get rapidly diffused into the alveolar tissues. As they are given through respiratory tract, they get diffused rapidly to the alveolar tissue, and it may cause the tissue barriers, and the depth of anesthesia will be depending upon MAC. I told you minimal alveolar concentration and partition coefficients are the two parameters which define the diffusible capacity of the drug or this inhalation anesthetic. So if they are more, and then the general anesthetic agent will cross or will penetrate into the tissue easily. And here the general anesthesia, inhalation anesthesia, once it's given from the alveolar, it reaches to the blood circulation, and from blood circulation it reaches to the brain, and vice versa. From the brain it diffuses to the blood, and from blood it reaches to the alveoli. What are the factors which are affecting the partition coefficient of the anesthetics in brain? So here, in order for the drug partition coefficient, in the sense the concentration of drug in two miscible solvents. So here the partition coefficient of anesthetic in the inspired air. So here whatever the gas we take or whatever the air we take, the partition coefficient of the air is determining the partition coefficient of the gas which is given as general anesthesia. And pulmonary ventilation as well as the alveolar exchange. So here the alveoli is the place where the gases are getting exchanged. So here the gaseous anesthetic inhalation anesthesia to have more diffusibility when compared to other gaseous substances in order to show better effect. And the solubility of the anesthetic in the blood. So here the solubility capacity of the anesthetic agent in the blood also determines the partition coefficient of the gas, whereby we can determine its potency, and the solubility in the tissues. So halothane is not soluble in the tissue because it is hydrophilic in nature. So it gets easily soluble. That is the reason it is not that easily penetrating into the tissue. If we see other general anesthetics, they are lipophilic in nature and they can be easily penetrating into the tissue. And the cerebral blood flow will be, the cerebral blood flow also determines if we give carbon dioxide inhalation, the cerebral spinal flow is impaired. So here the cerebral spinal flow also determines the stage of general anesthesia. How these general anesthesias are getting eliminated. So here mostly the entry route is the elimination route. So here we are giving the general anesthetic agents, inhalation anesthesias through lungs. So if we are giving through lungs, they will be exhaled out or they will be eliminated out of the lungs itself. And mostly they are eliminating through the lungs in the unexchanged or else they are eliminated through unchanged form. How they are entering? They are eliminated in the same way itself. And they are not undergoing any metabolic reactions. And they enter and persist in the adipose tissue for a longer period of time. So here, if the drug is having high solubility in nature, then it can easily penetrate through the adipose tissue and thereby it can stay for longer period of time in order to show its effect. And here the muscle tone, or else we can say the tissue, or for the drug to enter from the systemic circulation into the tissue, muscles are intermediate. So first, from the blood it has to cross through the muscle and then only it can enter into the tissue. So the penetrating of the drug through the muscle is also important, and it is excreted unchanged. These drugs are excreted unchanged. There will not go any metabolic reactions except halothane. So halothane is undergoing metabolic reactions and thereby it is excreted or it is eliminated as the metabolic product. And the recovery may be delayed in prolonged anesthesia. So if the anesthetic state is prolonged for longer period of time, then the recovery of the person from the anesthesia can be delayed. Second gas effect. So what is this second gas effect? So here tidal volume or the minute volume is the amount of the gas which is penetrating to the tissue per minute. So here tidal volume, in the sense it is the amount of gas or liquid which is penetrating into the tissue per minute. But here in the second gas effect, so here irrespective of the time, it enters into the tissue more. In the sense, for example, if we take in 1 minute 10 molecules of the gas or liquid is entering into the tissue. But here in that minute, n number of molecules can penetrate the tissue irrespective of the time. So the tidal volume is getting affected here. For example, if we take these nitric oxide and halothane, if they are given in combination in mixture, then they get penetrated more easily. This is called second gas effect, where if one anesthetic agent is combined with the other anesthetic agent, more amount of the drug molecules is getting penetrated into the tissue. Diffusion hypoxia. So hypoxia is a condition where the ability of the tissue to receive oxygen is less. So the tissue won't be able to receive oxygen, and if oxygen is not receiving to the tissue, then it may cause tissue necrosis. So here reverse happens during the recovery. So here while the person is recovering from the state, the diffusion capacity of the oxygen will be increased and it diffuses to alveoli and dilutes air in the alveoli. So here once if the general anesthesia is getting diffused into the alveoli, here, then it dilutes the air. So whatever, see, in the alveoli also we have air. So it is getting diluted. It is diluting the molecules of the air which is present in the alveoli, and then oxygen is reduced. So here, if the oxygen is reduced, or the oxygen reaching to the tissue is reduced, it may cause hypoxia condition. So in these conditions, the oxygen inhalations are given. So oxygen, why we keep oxygen mask during the surgery is because of the general anesthesia which is producing hypoxia. In order to prevent the hypoxia which is produced by the general anesthetic, we give oxygen inhalations. What are the techniques of inhalation of general anesthesia? So we are giving inhalations. So what are the techniques by which we can give inhalations? One is that one drop method. So one drop method is the oldest method. Here we are taking the inhalation anesthesia, and we are putting, or we are applying that inhalation anesthesia on cotton or some cloth, and we are directly putting that cloth or cotton into the respiratory tract, or as we can say we are smelling that anesthesia, and thereby just that one drop is nothing but one drop of anesthesia is causing the anesthetic state. So here we are directly smelling that anesthesia in order to produce the loss of consciousness. And there are the other method is through using anesthetic machines. So there are machines like open system, closed system is there, and semi-closed system is there. So there are different systems, different machines available which can induce anesthesia. What are the properties of general anesthesia? So how these anesthesias should be there? So for patients, in order for the patients, the anesthesia should be pleasant, in the sense the patient should be able to receive that anesthesia, and it should be non-irritating. It should not cause any irritation to the tissue, and it should be non-nauseating. It should not cause any nausea or vomiting to the patient, and the induction and recovery should be fast. So once we give anesthesia, it should induce anesthesia, and at the same time the person should recover from the anesthetic state fast. For the surgeons, the general anesthesia should provide analgesia. So if the surgeons are doing any surgical procedures, then it should not cause any pain. So it should induce analgesia to the patient. And then it should cause immobility. The person, immobility of the muscle should be there, muscle relaxation should be there, and this should be non-explosive and non-inflammable. So for the anesthetics, so these anesthetic machines are operated by the anesthesiologist or nurse anesthetics, who can take proper care of these machines in order to induce anesthesia. So for the anesthetics, it should be the margin of the safety, in the sense the general anesthesia should not cause, in the sense if we increase, or if the dose of the anesthesia is increased by mistake also, it should be safe. It should not cause any toxic, especially there should not be any fall in the blood pressure, and heart, liver and other organs should function properly. It should not affect those organs, and it should be potent, and it should be cheap, in the sense it should be available, cheap, and it should be easily available also, and it should not react. So here in the sense in the machines we have rubber tubings. So here this anesthesia should not react with the rubber tubings or soda lime, which is prepared, soda lime which is used for the preparation of these machines, and it should be rapid adjustment of depth of anesthesia should be possible. So here if the stages of anesthesia, or if the depth of the anesthesia is needed, then it should be adjustable, so that the person can reach to that stage of anesthesia as early as possible. Now let us see the classification of general anesthetics. So general anesthetics are classified as inhalations and injectables. So here inhalations are maybe in the gaseous form or in the volatile liquids. Volatile are easily evaporate. They are highly characteristic property to evaporate easily. And gaseous inhalation anesthetics include nitrous oxide, and volatile liquids include ether, halothane, N-fluorine, isoflurane, desflurane, and sevoflurane. The intravenous or injectable anesthesias are again categorized into inducing agents and slow acting agents. So inducing agents include thiopentone sodium, methohexatone sodium, propofol, etomidate. Slow acting drug include diazepam, lorazepam, midazolam, ketamine, and fentanyl. So, what is nitrous oxide? So nitrous oxide is a gaseous form of inhalation anesthesia. So here nitrous oxide is formed by the reaction of ammonium nitrate. So when ammonium nitrate is undergoing a reaction, it eliminates water molecule along with the nitrous oxide. So here this nitrous oxide is a colorless, odorless, it is not having any color, it is not having any smell, and it is an inorganic gas with sweet taste. It is having sweet taste and it is non-inflammable. It will not it will not burst out, or it's not flammable to flames or to heat, and it is non-irritating, but it is low potent when compared to other inhalations. And it is not that, or else it is less potent as anesthetic agent, but it is very potent as analgesic agent. So it will reduce the pain, or we can say it will not induce pain at all. And it is it is used as an adjuvant, or it is combined with other anesthetic agents in order to show better effect. Here one of the combination is that this nitrous oxide is given with oxygen and the other anesthetic agents. So here 70% of nitrous oxide is combined with 25 to 30% of oxygen and 0.2 to 2% of other anesthetic agents, which is used for the surgical procedures. And here the nitrous oxide can be combined alone with oxygen in order to produce in dental extraction. So in dental extraction, this nitrous oxide can be used alone with oxygen. What are the advantages of this nitrous oxide? So one thing is that it is non-inflammable, it is non-irritating, and it is having a rapid induction and recovery. So once we administer it, causes induction of anesthesia, and at the same time recovery is also fast, and it is a potent analgesic agent, and it will not cause any nausea or vomiting sensation, and it is non-toxic to the vital organs like liver, kidney and brain. The disadvantages of this nitrous oxide is that it is not potent as anesthesia. So it is not a potent anesthetic agent alone, and it may cause hypoxia. It may impair the oxygen carrying capacity of the tissue, and it inhibits methionine synthetase. So methionine is an essential amino acid which is synthesized. So methionine synthetase enzyme is inhibited by this nitrous oxide, and it inhibits vitamin B12 metabolism. So if it's not metabolized, it's not getting absorbed. And the dentist, it may cause some sort of risk to the dentist as well as personals who are using this nitrous oxide. So by mistakenly, if the personnel who is inducing the anesthesia by this nitrous oxide may inhale, which may cause which may cause the unconsciousness to the personnel or to the dentist or the healthcare professional who is doing these minor surgeries. And it is gas filled spacious. So if we use it in the open air, it may spread all over the air. The other drug is diethyl ether. So diethyl ether is a volatile oil, and it is a colorless. It is not having any color, and it is highly volatile. So if we expose it to air, it evaporates very easily, and it is having the boiling point at 35 degrees. So it is a point where the liquid gets boiled. So here the point at which the liquid gets boiled, once it reaches 35 degrees centigrade, it gets boiled and it gets evaporated, and it produces irritating vapor. So if we touch the if we inhale the ether, then it may cause some sort of irritation, and this is inflammable and even explosive also. So we should keep this away from the fire. And while a person who is using this diethyl ether should have mask, because if we inhale the vapors, then it may cause irritation to the nose or the region where it is exposed. The pharmacokinetics of these drugs are the pharmacokinetics involve that. So here this diethyl ether is eliminated 85 to 90% through lungs. So it is if it is inhaled, 85% to 90% is eliminated through lungs, and the rest is eliminated through skin, urine or sweat, and it can cross even the placental barrier also. What are the advantages? So here the halothane, the diethyl ether, it is not given through any complicated apparatus or equipment, just it is used through one drop method. Just our drop on the cotton or cloth can induce anesthesia to the patient, and it is a potent anesthetic, and it is even a good analgesic agent also, and it causes muscle relaxation. And if the dose exceeds a little also, there won't be any harmful to the person. So it is used within the safety margin, and it causes respiratory stimulation, and it causes bronchodilation, and it does not sensitize the heart to adrenaline. So here what happens is that in fewer general anesthetics, the heart becomes sensitized to the adrenaline. So if we give adrenaline, it will cause, the heart is very sensitive to adrenaline. So here diethyl ether, it does not cause this action, and it does not cause any cardiac arrhythmiasis. Cardiac arrhythmiasis is a condition where there will be dysrhythm in the heartbeat. Even the heartbeat is not altered by the diethyl ether, and it can be used in delivery also, and it will have less hepato and nephrotoxicity. So it is not that toxic to liver and kidney. So the disadvantages of these drugs are, one thing is that it is inflammable and explosive, so it should be handled very carefully, and on longer usage it may cause cardiac arrest, and it will cause a slow induction, and it is unpleasant. So here the induction of the anesthesia is slow, and it is not that pleasant to be inhaled by or it to be received by the patient, and it causes slow recovery, and it may have nausea and vomiting sensation, and it may cause convulsions in children, it may cause some seizures in children, and it crosses the tolerance. So here if it is given with ethyl alcohol, or if it is having tolerance with the ethyl alcohol. The other drug is halothane. So halothane is a general anesthetic agent which is fluorinated volatile liquid with sweet odor. So it is a fluorinated structure. So in its structure it is having fluorine groups, and it is sweet. It is having some sweet odor. So it is pleasant to smell. So if you see the structure, it is having three halogenes. Halogenes are nothing but halogens are nothing but chlorine, fluorine, bromine, and iodine. So here this halogen consists three of the halogens, that is fluorine, chlorine, and bromine. Especially it consists of three molecules of fluorine atom, and it is also non-irritant, and it is not inflammable, but it is sensitive to light. So when it is exposed to light, it gets degraded. So that is the reason it is preferred, or it is preserved in amber colored bottles, that is honey colored bottles. And it is a potent anesthetic agent, and 2 to 4% is enough for induction. So 2 to 4% of the drug is enough for induction, and in order to maintain the anesthetic state, 0.5 to 1% is given in addition. And the boiling point of this halothane is 50 degrees centigrade. So this halothane is eliminated unexchanged, so it won't undergo any metabolism, and 60 to 80% of the halothane is eliminated unexchanged, but remaining whatever the 20% is there, it is retained in the body itself. 20 to 40% which is the remaining percentage, it is retained in the body itself, and after 24 hours it is getting metabolized. So the advantages of this halothane are, it is non-inflammable, it is non-irritant, and it will not impair, the pharyngeal reflexes are not impaired. So here it does not affect pharyngeal reflexes at all, and thereby it leads to bronchodilation, and it is a potent inducer. So once it is administered, it causes induction, and it is very easy to recover from that anesthesia, and it is the hypotension or the blood pressure, fall in the blood pressure can be controlled by this halothane, and it inhibits intestinal and uterine contractions. So the intestinal and uterine contractions are inhibited by this halothane. The disadvantage is that it needs some special apparatus. So in order to induce anesthesia, some special apparatus is required to induce halothane. It is a poor analgesic agent. So it is not that potent to reduce the pain, and even to reduce the muscle relaxation also. And hypotension is caused because of the direct action of calcium. So here the fall in the blood pressure, If in severe conditions, it may cause fall in the blood pressure because of the action of calcium into the tissues, and it may cause arrhythmia, respiratory depression, as well as it may reduce the glomerular filtration rate. Thereby, it reduces urine formation. So, the rate by which the filtration in the glomerular apparatus is taking place is reduced, and thereby the urine formation is decreased. And hepatitis is very rare. That is 1 in 10,000 people this hepatitis condition is caused, and it may cause malignant hyperthermia. So, it will increase the body temperature and it may prolong the labor. The other drug is isoflurane. So isoflurane is containing the fluorine groups in it, which is bound with the oxygen atom. So here it is an isomer of N-fluorine and having similar properties, but it's slightly more potent when compared to N-fluorine. So it is just an isomer of N-fluorine, and 1.5 to 3% is enough for induction, and in order to maintain the anesthetic state, 1 to 2% is needed in addition, and it is given through special vaporizers. It requires some special apparatus in order to produce the vapors. The advantages of this drug is that it is having rapid induction and recovery, and it is a good muscle relaxant, and it even causes coronary dilation. So it causes dilatation of the coronary arteries, and it is causing less myocardial depression to adrenaline. In the sense, if we administer adrenaline along with this drug also, it will not cause any myocardial depression or cardiac depression. There will not be any renal or hepatic toxicity with this drug, and it is less, it will not cause nausea and vomiting, or we can say less nausea and vomiting can be induced. And the dilatation of the pupil dilatation is not observed with this drug, and even the light reflexes are also not impaired with this drug, and there will be no seizures caused. No seizures or no convulsions can be caused, and it may cause uterine muscle relaxation. So uterine muscles are relaxed with this drug. The disadvantages of this drug are it is not that good in smell. So it is having pungent smell. Pungent in the sense bad odor, bad smell, and thereby it is respiratory irritant. It may cause irritation to the respiratory tract, and it requires some special apparatus to induce anesthesia, and it may cause respiratory depression. And the main in the sense the maintenance is required. So the anesthesia maintenance is required here, and it may cause beta adrenergic receptor stimulation, which is not that good in anesthetic state, and it is very costly. The other drug is N-fluorine. So N-fluorine and isoflurane are isomers. So here this N-fluorine is non-inflammable, and it is having mild sweet odor. So it is having slight sweet odor, and its boiling point is about 57 degrees centigrade. And this is having the similar action with the halothane. So how halothane works, even the N-fluorine also works in the same way, but it is having the it is having less muscular relaxation. Halothane is having better muscular relaxation when compared to N-fluorine, and it depresses the force of contraction. The force of contraction of the heart is reduced, and it is sensitized, it makes the heart sensitized to adrenaline. And it induces seizures in deep anesthesia. So if the person is having deep anesthesia, it may cause seizures, and which is not recommended for epileptiform EEG, that is electroencephalogram. So in order to take EEG in epileptic conditions, then this is not preferred, and it is metabolized. The metabolism occurs 1/10 of the halothane. If halothane is undergoing metabolism up to 60%, then this drug have the metabolism capacity of 6%. So if the metabolic capacity of this N-fluorine is 1/10 part of halothane, and it does not cause any or else we can say it does not cause any hepatotoxicity, because it does not form any metabolites, and the metabolism releases fluorine ions. So on metabolism, the fluorine ions which are there in the structure, it will be released, leading to the renal toxicity or kidney toxicity. And these are the marketed formulations of isoflurane, N-fluorine, and desflurane, sevoflurane. Now let us see the injectable general anesthetics. So the injectable general anesthetics inducing agents and slow acting agents. The first one is thiopentol sodium. So thiopentol sodium is an injectable drug which come under the category of barbiturates, and this is an ultra short acting barbiturates because it is having a rapid onset of action. Once it is administered, it exerts its action, and it is water soluble and it is alkaline in nature. So it is having the pH greater than 7 and it is dose dependent. So the while we are giving thiopentol sodium, those should be adjusted in order to prevent the CNS depression or CNS related activity. And the dose is given about 3 to 5 mg per kg of IV route, and in the solution form, we have to give it in the solution form, and that should be administered within 15 to 20 seconds. So it should not have delayed, the administration should not be delayed. And the pharmacokinetics of this drug are, it is redistributed. So here, whatever the drug is there, it is getting metabolized. So what the unmetabolized form which is there, it is getting redistributed into the tissues again, and it is undergoing hepatic metabolism. So it undergoes metabolism in the liver, and its half-life is about 7 to 12 hours. And it causes CNS depression. So if this drug is having effect for longer period of time, it causes CNS depression. That is, if the drug is showing its effect for greater than 12 hours, then it causes CNS depression. The side effects of this thiopentol sodium are, it causes pre-anesthetic course, that is, it causes spasm in the larynx, and then it is not compatible with succinylcholine drug, and it causes tissue necrosis. So it may cause necrosis to the tissue leading to the gangrene, and it may cause post-anesthetic course, that is analgesic. So it can be used as analgesic agent after surgery, and before surgery it may cause spasm to the larynx. So the other drug is propofol. So propofol is, it is the drug which is replacing the thiopentol sodium. So because of the adverse effects of thiopentol sodium, propofol is replaced with the thiopentol sodium, and it is oily liquid substance. So it is oily liquid in nature, and that is the reason it is marketed as emulsion form. And it causes a rapid induction. Within 15 to 45 seconds of administering, it causes induction, and it will last for 5 to 10 minutes. So the action of this drug lasts for 5 to 10 minutes, and it is having a rapid distribution. So the distribution capacity of this drug is also more. It diffuses very easily to the tissues, and the half-life is about 2 to 4 minutes. So after half-life, half amount of the drug will be eliminated out of the body. And it is having shorter elimination half-life, in the sense within 100 minutes the complete drug is getting eliminated out of the body. And the dose for induction, so into induced anesthesia, the dose is about 2 mg per kg, and it is given in bolus form. It is not directly given through IV route, it is given through bolus of IV injection, and the maintenance dose of this drug is about 9 mg per kg for every 1 hour, and it is given through IV route because this drug is eliminated in 100 minutes. So the maintenance of the anesthesia, in order to maintain, the drug should be given through IV route. And propofol is metabolized up to 88% in the liver, and it is eliminated through urine, and it is metabolized by a process of conjugation reaction. So it is one of the metabolic reactions occurring in the liver. So the uses of this propofol is that it is used to treat hypovolemic shock, and it is used to treat hypovolemic shock, and it is used in head and neck surgeries, and it is used in asthmatics. And for short surgical procedures is preferred, and for outpatient department surgical procedure also this propofol is preferred for angiogram and cardiac catheterization. So in order to induce catheter into the cardiac or coronary artery, this propofol is mostly preferred. And the other drug is ketamine. So ketamine is a phencyclidine derivative. So it contains a structure of phencyclidine. So in its structure, phencyclidine ring is present, and it is dissociative anesthesia. So it may cause some dissociation or disturbances in the anesthesia, and the induction period of this ketamine is also for long. So that is the reason this ketamine is given in combination with other anesthetics in order to prevent the dissociative anesthesia. And the site of action of this ketamine is the cortex region and subcortex region, especially the NMDA receptor. So these NMDA receptors are present in the cortex and subcortex region, and this drug will bind to the NMDA receptors in order to show its effect. And the dose is given about 5 to 10 mg per kg if we are giving through intramuscular route, that is IM route, and if we are giving through IV route, 1 to 2 mg of drug is enough. The disadvantages of this drug is that it causes limb movements and nystagmus. So the limb movements can be impaired. And it may cause nystagmus. That is, the movement in the muscle is lost, and it's required. I mean, in emergency phenomena only we can give this drug, and it may cause hypertension, and it increases the IOT and ICP, that is intraocular temperature. It can be increased, and it increases the intracranial pressure, the pressure inside the cranial region, and it may cause uterine stimulation. It will stimulate the uterine muscles, and it will cause psychosis and schizophrenia, and the laryngospasm. The spasm in the larynx region is very rare, but it causes, the muscle relaxation with this ketamine is very poor. The other drug is fentanyl. So fentanyl is a neuroleptic analgesia. So it causes analgesia to the neuroleptic region if it is given with droperidol, and it is a 4-acyl anilino derivative. So it contains anilyl ring in its structure, especially at the C4 carbon atom, and it is an opioid analgesic. So it causes analgesia by binding to the opioid receptors, and the duration of action of this drug is about 30 to 15 minutes. So the uses of this fentanyl: if the fentanyl is given in combination with diazepam, that is low acting drug, so if we combine with this, it is used as the diagnostic agent in endoscopies and angiographic procedures, and it is used as an adjuvant. So this fentanyl can be combined with the other anesthetic drugs to produce spinal anesthesia or nerve block anesthesia. The advantages of this fentanyl is that it is having the smooth onset of action. It is having good onset of action as well as good recovery as well, and it will not cause any vomiting or cough, and it is having commanded, during the surgical procedure or during the operation, it produces the anesthetic effect, and it will cause less fall in BP. In the sense, the blood pressure fall will be reduced. The disadvantages of this drug is that it will cause the respiratory depression. So this fentanyl is having the disadvantage of respiratory depression, and it will cause nausea and vomiting on overdoses, and it will increase the tone of the chest muscle. So in the chest region, the muscle tone will be increased, and it may cause itching also. While the person is recovering from the anesthetic state, it may cause itching. Now let us see the complications of the anesthesia. So what are the complications if the general anesthesia is prolonged for longer period of time? So here it may cause during the anesthesia. So while we are giving the anesthesia, or during the anesthesia is caused, it may cause respiratory depression, and it may cause the salivary and respiratory secretions are reduced, and it may cause cardiac arrhythmias. There will be disturbances in the rhythm of the heart, and there will be fall in the blood pressure, and it may cause aspiration. There will be difficulty in the breathing, and it may cause spasm to the larynx, and it will cause delirium and convulsions. So delirium we saw in the stages of general anesthesia, and it may cause convulsions also, and it is explosive. It is flammable. Here after anesthesia, what are the complications? So the complications are that, what are the complications after the anesthesia is induced, or after the recovery from the anesthesia? The person may feel nausea and vomiting, and there will be sedative effect. So the sedative effect will be persisting, or the sedative effect will be continuing for a few period, and it may cause pneumonia like symptoms like cold and flu, and it may cause the damage to the liver and kidney, and it may cause nerve palsy. The nerve functioning will be impaired, and it may cause delirium, and it may cause cognitive defects also. The defects of the eye will arrest the visibility of the eye, or eye impairment will take place for a little period. What is pre-anesthetic medication? So pre-anesthetic medication is a treatment or a procedure which is given before inducing anesthesia. So these anesthetic agents are having greater side effects or disadvantages. So in order to make this anesthetic drug safer and more potent, we are giving the pre-anesthetic medications in order to in order to prevent the side effects of this general anesthetic drugs. So what is the aim? Why we are giving this pre-anesthetic medication? So one thing is that in order to relieve from the anxiety state, and the other one is it may cause amnesia for pre-operative as well as post-operative events. There will be memory loss, and analgesia can be induced, and it causes decreased secretion. So whatever the over secretions are there during the anesthesia, that may be decreased by this pre-anesthetic medication, and it may cause anti-emetic effects. So whatever the nausea and vomiting sensations are there during and after the anesthesia, that may be reduced by this pre-anesthetic medication, and it will decrease the acidity. So the volume of the gastric juice or the gastric juice release can be reduced, and thereby it may reduce the acidity. What are the drugs which are used to give the pre-anesthetic, or what are the drugs which are used in pre-anesthetic medication? So the drugs like sedatives and anxiolytics like diazepam, lorazepam, midazolam and promethazine are preferred, and opioids like morphine and morphine analogs, anticholinergics like atropine, H2 histamine receptor blockers like ranitidine and famotidine, and anti-emetic drugs like metoclopramide and domperidone. So these are the drugs which are given prior to induced anesthesia. Before giving anesthesia, these drugs are given as a pre-anesthetic medication.